Hello, everyone, and welcome to week two of our journal club presentation here at the Rugby Research and Injury Prevention Group. Today, we will begin with our first intern, Philip Tessick from the University of Michigan. Philip, whenever you're ready, feel free to share your screen.
My name is Philip Tessick, and I'm a rising sophomore at the University of Michigan. And today I'll be presenting on an observational cohort study regarding tackle-related injury rates in South African youth rugby tournaments. And starting off, this journal article defined the tackle in somewhat of an interesting way, but they defined it as any event where one or more tacklers, players, or uh, player making a tackle attempt to stop or impede the ball carrier, player carrying the ball, whether or not the ball carrier is brought to the ground. I think we can get back to this in a little bit, but I thought that using the word tackle twice in this definition was was a bit problematic, but we'll get to that later in the limitations. But before they got into the methods, they cited that the tackle was responsible for a high proportion of upper body injuries in tacklers, um, particularly the concussion and the head and neck and shoulder injuries, and ball carriers were more likely to sustain injuries to the lower parts of their body, including the thigh muscle and knee injuries. And despite the large amount of adult tackle studies, less was known about the youth cohorts. And this study aimed to answer the questions regarding the nature and rates of tackle-related injuries occurring at South African youth rugby tournaments. And they did this through four youth tournaments from both in 2012 and again with those same four tournaments in 2011, then the same tournaments in 2012. What was interesting about these tournaments is that they spanned 1 week with high match loads. They were very intensive tournaments as opposed to what we see more in other parts of the world where there's a 1 day tournament or a 2 day tournament with a high intense match load. This instead was, interestingly enough, a high match load over stretched out over a full week. The questions regarding the study were the nature of the injury rate, how these injury rates differed, um, the injury type proportions, the anatomical locations, especially between the ball carriers and tacklers, as well as if the rates of injuries increased as the matches went on. So the way that they collected data through this research project was that in order to enroll as part of the tournament, the players had to sign on for their consent form, and part of that consent form involved injury surveillance project that was conducted through this research team to collect data. And this was done at four tournaments for over 2 years with one under 13 tournament, one under 16 tournament, and two under 18 tournaments. And interestingly enough, the study actually did not mention rugby 15s until they explained that the teams were consisting of 22 players and that there were the four quarters with a total of 80 minutes of match playing time. Looking at the way that the study was conducted, injury definitions in the surveillance system were adapted from the Rugby Union Injury Consensus Statement, and this study specifically looked at time loss, medical attention, and tackle-related injuries as a part of their methodology. They especially looked at injury type classifications that were mentioned in the paper, such as concussions, spinal cord fractures, joint ligament and tendon injuries, muscle, bruise, lacerations, and of course, other injuries. These incidence rates were calculated using total exposure hours reported per 1,000 player hours of calculated by the time that the players were on the field and reported with the necessary confidence intervals. Looking at the results, there was somewhat interesting results here in between the the shifts in years from the two tournaments. So in this under 13 tournament, there was actually a much higher rate in overall injury rates in 2012 as opposed to 2011, as well as the time loss injury rates. And in the one of the under 18 tournaments, we saw something similar, except a large decrease in the time loss injury rates. But otherwise, there were relatively similar injury rates across the tournaments with very high confidence intervals that led to somewhat statistical significant results in certain areas. However, there were no certain significant differences in overall and time loss injury to tackle related injury response rates for the tournaments from 2011 to 2012. But there was, as I mentioned, a significantly greater tackle related time loss injury at the 2012 under 13 tournament compared to the 2012 under 18 tournament. And that would be this one of these 2018 to 2012 under 18 tournaments compared to the 2013 tournaments. But otherwise, there wasn't much of a difference in the injury incidence rates, whether they were overall or time loss rates between the different tournaments and years. Looking at the differences between ball carriers and the tacklers, 60% of overall injuries from these tournaments were regarding tackles, and 61% of them were to the tackler, while the other 39% were to the ball carrier. We saw very similar proportions when looking at time loss injuries, in which out of all of these tackled related injuries, 61% of the time loss injuries were tackle related injuries, with again, slightly more of them occurring to the tackler, with a small minority of them going to the ball carrier. Looking at the anatomical differences, there was very significant findings in the differences between where these injuries occurred in the players. So regarding the upper torso, there were not very different injury rates, but injury proportions between tacklers and ball carriers. However, when looking at overall injuries, we saw much different uh, anatomical injury location prevalences in the tackler for higher proportions in head and neck injuries, as well as lower proportions in the lower limb uh, regions. This also carried over with similar rates in the time loss injuries, in which the tacklers had higher prevalence head and neck time loss injuries and a lower prevalence of lower limb time loss injuries. The largest proportion of overall tackle-related injuries were joint, ligament, and tendon injuries, followed by bruising, muscle, concussion, and laceration injuries. The greatest proportion of tackle-related time loss injuries were to the joint, ligament, and tendon classification. When looking at the research question regarding if these injury rates continued to increase as the time went on, the highest rates were in the fourth quarter, followed by the third, second, and first quarter, with significantly more tackle-related timeless injuries occurring in the final quarter compared to other times in the match. Looking at the overall conclusions of the study, we can see that tackle-related injuries made up a high proportion of all injuries in this observational study, which was relatively consistent with previous studies, however, with somewhat different rates. Tacklers had a higher proportion of both overall and time loss injuries, though the literature is conflicted on whether tacklers or ball carriers are at a greater risk, which is in somewhat contradiction to this study when compared with previous literature at the time. Overall tackle injury rates ranged with a very large confidence interval from 23.8 to 50 injuries per 1,000 player hours, which was similar to Premiership Rugby Union, as said in the article, but also much higher than the community level rugby played in England, which again is a somewhat interesting comparison to make, being that these tournaments were youth tournaments in South Africa. Injuries increased as matches progressed, as indicated by their data with the highest rates of injuries occurring in the final quarter, statistically higher than previous quarters. And this was mentioned in the article as likely due to fatigue, which can impair tackle technique and lead to poor technique and ultimately more injuries. And this led the authors to emphasize the importance of coaching to rotate out the squad to make sure that players are more fresh and they're not as fatigued, as well as just to be overall aware of the fatigue going on in their players. The general consensus that was sustained from the results of the study were that the tacklers are more likely to suffer head and neck injuries, while the ball carriers sustained more lower limb injuries, which was in line with previous cited studies. One of the a known injury risk factors cited was poor tackle technique, which was cited as possibly leading to these higher injury rates. And the authors mentioned that coaches going forward should use this data as a reason to emphasize an early teaching of proper contact technique to instill that into players as they are young, as of course we looked at a youth study right here. Looking at limitations, going back to my first slide when I discussed their definition of tackle, I was not quite a fan of the way that they define tackle while using the word tackle in their definition of tackle. The consensus statement that is widely used by these rugby studies is more regarding injury classification and does not have a clear definition of tackle, but instead bases its definition of tackle on World Rugby. So I believe that this study should have used that definition from Rugby that the consensus statement uses. Um, which is defined as when the ball carrier is held by one or more opponents and brought to the ground, which of course is better than saying, for example, when the ball carrier is tackled by one or more tacklers. It also never specifically said that this was rugby 15s, and the only way to know this was when they mentioned that each team uh, included 22 players in their methodology, as well as the difference in quarters and time playing throughout the match. The study also may not be able to be generalized since it is such a specific cohort of youth rugby players in South Africa, specifically at these very specific age ranges of under 19 tournaments, under 16 tournaments, and under 18 tournaments. There was also, interestingly, a lack of lower limb injuries in the ball carriers that was not reported on in the study, while it would have made sense that there was missing proportions, as proportions of the other anatomical regions did not add up to 100% by themselves. The tournaments were also um, they were also very intensive for 1 week, which is difficult to sort of spread to a broader conclusion regarding the nature of this observational cohort study, since there was a lot of matches in a short amount of time with little rest, potentially inflating the injury rates of these players. With that, here's the reference, as well as I'm welcome to any questions at the moment.
Thank you so much, Philip, for that informative presentation. If there are no questions from the interns or Dr. Lopez, we will move on to our next presentation. Our next presenter is Gabriel Moreno from Adelphi University. Gabriel, whenever you are ready, please share your screen.
All right, good afternoon, everybody. Thank you, Asha, for the introduction. My presentation is going to be on a video analysis of concussion injury mechanisms in under 18 rugby. This was in the Journal of Open Sport and Exercise Medicine, and it's a 2016 article. So, what was the purpose of this study? This article was published, to give some context, it was before the 2020 Rugby Union video analysis consensus paper, so it could be that some of the methods or variables may not match the standard that was set after this consensus statement. The goal of this paper was to understand exactly how concussions occur in youth rugby, but also to help inform better injury prevention strategies for later on. One of the reasons they chose video analysis is because it gives detailed information about the player movements, and the context of each injury after all the stress of the game goes away. And what's new here that I haven't seen in other studies is that the study compared injury events with a matched non-injury sample. So a limitation of other studies was that they only looked at injury events without comparing it to similar safe plays. And to explain what this is, a matched non-injury sample, it's a play that's very similar, so it involves the same player in a similar situation where no injury occurred, and this allows for a direct comparison of the injury causing scenario versus the safe scenario. So now let's talk about the data collection. Where was this data gathered? It was gathered in South African Rugby Union in the Coca-Cola Youth Week tournaments, in the Under 18 Craven Week tournaments from 2011 to 2013. There were 18 concussions reported, but only 10 had usable video for analysis. There were also 83 similar non-injury plays that were chosen for comparison. Like I said before, for each injury that they analyzed, they found a similar moment in the same games with the same players. This was also on video. The software that was used was Sports Code Elite version 6.5.1 on Apple Mac, and they were reviewing the footage at 25 frames per second. So, what variables were collected? I found this to be very important because every article collects similar yet different variables. One of the big things that I noticed was that they had the player's team, their height, the weight, which is a big thing, the age, insurance, which I hadn't seen before, and protective gear. So, from the video, this isn't everything, but this is from one of the first tables. They had the head position, which was either up and forward or down and away, the player speed, the player role, let's say if he was a tackler, support, or a jackal, the awareness of contact. So let's say, did this player know that they were going to be tackled? Did they anticipate this or not? And the phase of play, was it a tackle? Was it a ruck? Or was it an aerial collision midair? And they also had which body region was struck, both from the tackler and the person who was getting tackled. For some clarification, the down position is when the head is tucked down toward the ground. Up is obviously the head facing at the opponent and the chin is up. And a support and a jackal. So it is defensive players at a ruck, and the jackal tries to take the ball from the player that's on the ground. Now, these are a few tables that I found very interesting. What I highlighted here in the red box is the acceleration direction of the head. I found this really important because we might be able to translate this to our future studies. And so what this did is, how did the head move after impact? So was it a sagittal plane? Was it forward to backward movement? Was it coronal, so side to side? Was it rotational? This was very interesting to me because it shows there's very different ways to analyze the data that we're going to collect. Another thing that I found very important was that they had two different speeds. They had the speed of the concussed player and the speed of the other player, which made sense. But they also tracked the movement and speed of the body or the region that was in contact. So they said, let's say if they hit me in my chest, how fast was my chest moving? Or the person that hit me with their chest, how fast was their chest moving? Was it slow, moderate, or fast? Now, a big thing in journals and stuff is how did they define the vocabulary that they use? So, how did this article identify concussions? They said that a concussion is a complex process affecting the brain caused by biomechanical forces, so movement. Before every tournament, all the tournament doctors they were informed of the most recent concussion protocols and consensus documents to evaluate and help manage these concussions. This is important as well. So for the tournaments in 2011 to 2012, they used a 2008 consensus concussion consensus statement. But from 2013 onward, there was an updated 2012 consensus statement, which they used. The reason I bring this up is because as rules and protocols change over time, the definition and standards for diagnosing or managing or even preventing concussions or any other injuries is going to shift. So, for example, recently, World Rugby, they lowered the legal tackle height in community rugby to below the base of the sternum. And this was based on new evidence about safety. So, this is important for us to keep in mind because when we're going to analyze older video footage, it's very important to remember which rules and definitions were in place at that time. Because if we judge those past injuries based on today's standards, we might misinterpret what was safe or what was unsafe at that time. So it's important to have clarity and clearly state which protocols and definitions we're going to use just for consistency and clarity in our data. So these are the results. All concussions of the 10 that they analyzed were from player contact, and it wasn't hitting the ground or solo falls. 60% of the injured players, they didn't see that the hit was coming. And for the head position, 43% had a head down, 29% had up and forward, and 29% were looking away. For the speed, the injured tacklers were moving slow 60% of the time, and most ruck concussions were defensive roles, so it was either support or jackal. 60% of the concussions occurred in the fourth quarter. This suggests that fatigue is a major risk factor for injury in youth rugby. In our protective gear, this is one of the variables that they tracked, but very surprisingly, there was only one player that used both a scrum cap and a mouth guard from the data that they collected, which is very surprising to me. I want to go over this statement a bit more just to explain, since I know not many of us are familiar with rugby, but I had said that the speed and the injured tacklers were moving slow 60% of the time. And then I said this was done a ruck and with jackals and support. So what is a ruck in rugby? A ruck happens after a player carrying the ball has been tackled and is on the ground. So players from both teams are going to gather over the ball, try and get it. And the aim is to push each other away to win possession. But nobody is allowed to use their hands to pick up the ball until this ruck is over. And they use their feet to move or protect the ball. Now, what is a support or jackal during a ruck? What is their goal? A support player is helping their team during a ruck. They usually protect the ball for their side or they push against the other team to win the ball. A jackal is a player that's usually on the defense who's trying to win the ball back by getting their hands on it after a tackle. Often they're staying on their feet over the ball, and this is called jackling, and it's a skill that can help change the possession very quickly. So, some conclusions and prevention advice from this article. They recommended that athletes should train peripheral vision and awareness because when the athletes were aware of the incoming impact, the chance of concussion lowered a lot more. They also suggested to strengthen neck or cervical muscles, which is what they said. But they also said to use conditioning to better prepare for fatigue that happened in the fourth quarter to lower injury rates due to fatigue. A big thing was injury rates or concussion rates increased when they had bad head positioning. So a big thing was to coach safe and effective playing techniques. So keep the head up and forward during contact. To be clear, what is safe and effective technique? This is keeping the head up, forward, good body positioning, and driving your legs after contact while also maintaining awareness. What are the limitations of this study? The sample size was a bit small. It only analyzed 10 injuries, but the reason because of this is due to the low quality of the videos analyzed. Keep in mind, these videos were from 2011 to 2012. They don't have the iPhones that we have today. The next thing is that they had the weight of the players and they also had the speed, but they didn't do any force measurements of collisions, even though they had this player weight. Another thing is that the methods might not meet the current video analysis standards, which makes sense because the consensus on video analysis came out in 2020, and they only looked at data in South African rugby. However, this study is really important because it sets a groundwork for larger or more standardized video studies in youth rugby. I wanted to include this because this could be a bit more practical in the way that we could use and learn from these little lessons that we have so that we could help our studies. So something that I think would be important is doing match non-injury controls. Throughout the match, there's going to be many times we'll see tackles, and most of the time these injuries don't happen. So let's compare these injury and non-injury plays in our studies because this can help pinpoint real risk factors by comparing a same athlete and his behaviors, let's say before injury or during the tackle during the injury causing event. A big thing as well is to standardize variables. We could update and refine the variable list that we have by using examples from this article. And what I mean by variables is how they had the head positioning with left, right, things like that. And also by using newer consensus guidelines. And the third thing is to highlight areas for improvement. So we could add the force measurement, use more advanced coding software compared to what they used in 2012. And we could also include a lot more videos and games because they only used 10 videos that were of good enough quality to be analyzed. This is the reference. If anybody has any questions, please feel free to ask.
Thank you so much, Gabriel, for that presentation. If no one has any questions, we will move on to our third and final Journal Club presentation of this evening. Our final Journal Club will be presented by William McIntyre from Howard University. William, whenever you're ready, please share your screen.
How's everybody doing? My name is William McIntyre. I'm a rising senior at Howard University, and my presentation is on the epidemiology of injury in elite English school rugby union. It's a 3-year study comparing different competitions. It's by Craig Barden, Keith Stokes, and it's from the Journal Athletic Training from 2018. So first, I want to talk about the aims. So the aims was to investigate the injury risks in senior English schoolboy rugby, and it was to also to compare the risks for those taking part in elite competition, which is the AASE. Basically, what that is it stands for Achieving Academic and Sporting Excellence. This league established in 2004 in England by the RFU to support a structured pathway for youth rugby players. And with that being said, is also to compare with that to the non-AASC teams. So that could be like same college teams, but also not standard competition teams, the lower standard competition teams for friendly matches. So injury surveillance. So the injuries were taken a look at by the 24-hour time loss injury as per the consensus statement. And also the training attendance was compulsory, meaning that you had to go to training sessions each and every time, you couldn't skip it. And also those who were unable to train were assessed by the medical team, because obviously that means they're probably injured or don't want to practice. And that was to ensure all injuries were captured in the study. And the data was collected using the O6. And what that is the Orchard Sports Injury Classification System. It's basically a coding system used in sports medicine to classify and record sports injuries in a systematic, consistent, and detailed way. It's mainly used in rugby and it's really helpful to organize your data and collect data and to get together, if that makes sense. It also is to uniformly describe injuries across teams, leagues, and research projects. And what this does, it looks at the injury, for example, looks at the injury incidence is reported per 1,000 players of a match, and also the burden is also organized the same way, like mean severity, if that makes sense, and then 3 incidents per 1,000 hours. So a brief overview of the study. The study was performed over 3 seasons from August 2012 to May 2015. And the rugby union consists of 16 to 17-year-old males. This is around like the late high school time, intercollegiate time, so around that time. And the study was consisted of 132 players with the mean age of 17 and a half years old. And then the academy consisted of 3 teams who use the same coaches, medical team, and facilities. This is important because it's important to have controlled variables in a study so that your data is getting the same results each and every time. Nothing could be fixed or independent, if that makes sense. So the first team participated in the AASE League, which is RFU's flagship for competition in intercollegiate teams. And that team played 42 matches, whereas the second team participated in under 19 intercollegiate league and they played 59 matches. And the third team was also a non-AASE team. They played matches as well. And all three of these teams played under 19 exhibition matches throughout the season, and that consisted of 30 matches played. And all the teams followed the same weekly structure of two strength and conditioning sessions and two pitch-based training sessions and one match per week. This is important, like I said before, to have controlled variables so we know we're getting the same results and as nothing will be changed or fixed in the study. So these are the results. The table is categorized by the name of injury, the incidence rate, severity, and then burden. And this is the ASC side. This is the non-ASC side. It also is looked at the nature of the injury, so the general location, if it was head or neck, upper limb, lower limb, and then the type, if it was a fracture or muscle contusion or something that happened in the central or peripheral nervous system, which means a concussion, and the mechanic and mechanism, if it is a tackle or the person was being tackled or a ruck maul or a collision. So a couple things I want to point out is from the 131 matches, 34 AASE and 97 non-AASE were recorded a total of 103 injuries. Over the 3 seasons, the injury incidence rate for AASE matches was 77 per 1,000 hours. And also the non-AASE matches had an injury incidence rate of 34 per 1,000 hours. And lastly, the central peripheral nervous system injuries occurrence in AASE matches was 24 per 1,000 hours. And whereas the non-AASE matches were 4 per 1,000 hours. That's a big difference, especially since this means that most of the central and peripheral nervous system injuries were concussions. That means that as competition increases, that means more head and neck injuries and upper body injuries will increase. Also, tackles were the mechanism for greater than 50% of injuries in both groups. This is because tackles in rugby are the most physical play you could do, and it happens more times than not. It's a tackle every couple seconds or so. So yeah, for the location. The bias location with the highest injury rate was, like I said before, the head and face and the central peripheral body part of the body. And a major contributing factor to the high incidence rate of the head and neck injuries in the AASE matches was the high rate of concussions, like I said before, which had an incidence rate of 20 per 1,000 hours. And that accounted for over 80% of all the head and neck injuries recorded. And also, like I said before, sub-elite matches generally showed lower injury incidence rates across most body locations compared to elite AASE rugby. This is a chart right here that gives a better information, a better show of all the parts of the body where the injuries were located. As you can see, like I said before, the head and face led the way with the most incidence rates and confidence intervals. Whereas to the bottom is more lower body parts like the calf and the foot and the pelvis, whereas the upper body parts like the shoulders, face were towards the top of the graphic. So some of the variables that were contributed to the study was like the matches played, the player matches, and the injuries and the incidence rates. So lower limb injuries were prominent during non-AASE matches, with upper limb and head and neck areas having a higher incidence rate in the AASE group, like I said before. And the injury burden was greater for AASE matches. It had an incidence rate of 1,545 days per 1,000 hours. And it also had a 95% confidence interval rate. And that's compared to the non-AASE matches, which had a incidence rate of 648 days of absence per 1,000 hours. One thing I want to point out too is the incidence rate and burn rate of shoulder injuries were highest of any upper or lower limb region. And also the mean severity of injuries was 20 days, about 20 days, and whereas in AASE matches, whereas for non-AASE matches, it was 19 days. So it was around the same time for both AASE and non-AASE matches. So injury mechanism. So when a tackle occurred, it was associated with more than, like I said, 55% of all injuries. Like I said before, that is because tackles are the most physical play in the sport of rugby, and tackle happens more times than not, very high likely chances in a lot of times. So yeah, and also reported throughout all levels, the occurrence rate for AASE matches was 42 over by 1,000 hours, and that nearly doubled. Well, it did double. The non-AASE matches was 19 per 1,000 hours. In a correlated study in South Africa, it was conducted on tackle injury rates in multiple youth rugby tournaments, and this is under 13 and under 18. And they found that the risk of tackle-related injuries increased significantly as each quarter of the match ended. and a total of 37% occurring in the final quarter. That could be mainly due to fatigue. A lot of times when players are tired towards the end of the matches, they really just want to give it all, and they're not really thinking with their brain. They're mainly thinking with their heart and their passion and what they want to do. So when they make the tackles towards late games, that means the body's more worn out, they're more tired, they're more fatigued, and that will cause them to make not necessarily smart decisions, but also decisions that were made to win the game and more passion, if that makes sense. And also, like I said before, working in a fatigue state has been suggested to decrease the incidence of fatigue-induced injuries. So some strengths of the study was, like I said before, the high level of medical access that the athletes receive. All athletes received, no matter the squad, had equal access to the medical team, and no bias was given toward either group. And concussions may also have been missed, but especially during the non-AAC matches where coaches rather than medical professionals provided first aid. Also, if an injury was noted by the pitch side aider, the medical team will also been made aware, and the athlete will be able to train. So, like I said before, communication between the medical teams is very important because a player might be injured during the game, but the actual athletic trainer might not know, and he might end up practicing, but he shouldn't have. So, it's really important to have communication from both sides and all medical teams so they know what to do and how to treat the injuries. And also, if an athlete was injured during the game, but he will not be able to train 2 days later, the injury would not have met the time loss definition used. So basically, what that means is the study was recorded injuries that caused an athlete to miss training 2 days after a match, and whether a medical professional or a coach was providing pitch side first aid, he would not be able to affect the difference in injury rates between the groups. So it's important to note that injuries had to be more than 2 days. So whether an athlete might have had a cut or a scratch or a bruise, he can still practice doing that. So it's important to note that the injury severity matters when it comes to collecting data. So some limitations of the study was possible misconcussions. Most concussions lack visual symptoms, and players may have continued playing or played through the concussion without being identified. Also, concussions may have been missed, especially due to during the non-ASC matches where coaches rather than medical professionals provided pitch side first aid assistance. So when a player gets hurt and comes to the sideline, a coach might say, "Hey, are you okay?" The player will say yes, and then okay, you back in. So it's really important to note that all players must be looked at by medical professionals because it's important to note that if a player might not say he's injured or not, he might not know, and he might just want to get back on the field as quick as possible when it's important to know the player is hurt and he needs to get the right assistance needed. And also, injury definition excludes minor or short-term injuries. So, like I said, if a player missed two, or if he didn't miss two or more games, then he won't be included in the study. And also, minor injuries or injuries that resolve within 48 hours were not included. So that could lead to underreporting or short-term injuries. So, like if a player maybe had a rolled ankle and he really wasn't practicing on it one day, he might go back on the field and play the next game if he possibly could. So to conclude, risk of injury was greater for schoolboy rugby players when they were participating at a higher level of competition. So the AASC matches had a higher confidence interval rate and also confidence rate, so that it improves the study. And the AASC group, like I said before, found a concussion rate greater than that of any previously published youth rugby study, and the rate and burden rate of the shoulder injuries were prevalent in both groups. So these findings help to support the purpose of ensuring access to quality medical staff during matches. So it's important to have good medical staff during all the matches, and that means good ATs, good trainers to help ensure that the athletes are getting the best care possible, and also to implement robust injury surveillance systems. So like it's important to know that athletes sometimes they might be injured, but then might not say they're injured. So it's important to have people that can identify injuries when they happen and to know the best treatment for the athlete. And also to develop conditioning and intervention programs to reduce injury risks in youth rugby. And there's some references, and that's it.
Thank you so much, William, for that presentation. If there are no questions from the interns or Dr. Lopez, I will conclude our journal club presentation. Thank you, everyone, for joining us for week 2 of our journal club here at the Rugby Research and Injury Prevention Group. We will not now move on to our professionalism series.